Hvidsten, and please make the most of the talk and ask her any questions that you have. Thank you.
Thank you, Mel. I'll rely on my helpers to point out if I miss a hand being raised. I'll keep an eye on the chat function, and like that's been said, I'm happy to respond at any point through the presentation. So I'm going to talk about autism, when it is a good idea to refer, when to ask for help, and then, what can be done. Just going to quickly recap on the features of autism, because certainly thinking back to when I finished medical school, what I was taught at that point is very different to what I see in clinical practice. So I hope it's helpful to just point out what it is that I get to see on a daily basis. So the central sort of issue with autism is this proposed lack of theory of mind. So that's the ability to recognize and understand other people's thoughts, beliefs, desires, and intentions. So to kind of anticipate what the other person's thinking. And that is absent or reduced in autism. So you can understand that that would make it very difficult to have intuition about a situation, or to read the situation, or to really understand, are people cross with me? Are they happy with me? Are they shouting? So it leads to a lot of literal interpretations. It can make the young person and adult on edge, almost sort of paranoid, because they're really expecting the worst all the time, because everything comes as a surprise. It can mean that they sort of appear disrespectful and rude. I think we've all had the experience of when we're stressed ourselves, it makes you a bit more snappy. But if they're living like that all the time, and they think that people are having a go, then they can just come across as quite rude and prickly. Having to try and work everything out from scratch in terms of, interpreting facial expressions, are they shouting, are they cross with me, rather than just being able to rely on intuition, is exhausting. They find social interaction very difficult and very wearing, and it just makes it much harder to work everything out. And often it might mean that they don't see that the other person is genuinely trying to help them. So for example, at school, they might perceive that the teacher's being patronising when actually they've just been trying to help. So then it just kind of leads to this sort of sense of loneliness and rejection, and everything kind of can snowball from there. So next slide, there we go. I've tried to make these slides as not busy as possible, but I haven't always managed. So the symptoms and signs that you might see. So there's a discrepancy between the language that they produce and that they comprehend. So often they can appear more verbally able, their comprehension can appear more elevated or more skilled than they're actually at their ability to understand. And that often leads to things not being recognised. Early on, you might see a lack of symbolic play, preferring to play alone, not particularly wanting to play in a group, struggling with reciprocal social interaction, and struggling with attachment. So this is the bit that's often difficult for parents, because they're really just not getting that feedback from the child. Not as many friendships as you might expect, and an abnormal response to other people's emotions. So a story I heard the other day was, a child would be in nursery and one of the play dolls would start crying, so they would cry as well, because they don't really understand how to necessarily react to other people's emotions. And you can understand that would make friendships really quite difficult. You don't always see a delay in the language development, so certainly, when we're taught about this at medical school, it'd be like language delay and, these sort of repetitive play type behaviours, but you don't always see that. They might be rather eccentric, with sort of interests in sort of, cryptocurrency at the age of 9, or, really passionate about physics, all of which are excellent, but it's not something that would be in keeping with their peer group, and it makes it more difficult for them to have a friendship group. They often work very, very hard to mask their difficulties, because you can imagine their worst case scenario is drawing attention to themselves. They really don't want the teacher to come over and start helping them. So they often mask, the fact that they're struggling. And so it can look like disengagement. And again, with this sort of snappy responses, they just start to look non-compliant, rude, lazy, and start to get, suspensions and, behaviour points and things like that. The preoccupations and obsessions, this can be anything from moshy monsters, as it was a few years ago, to you know, volcanoes. It really, really varies. And sometimes it's something the parents are quite proud of, because, you know, they can say their alphabet backwards, or they know all the flags of the world, and everybody will think it's very cute and kind of precocious sort of knowledge. But what they have to understand is that the child's doing that because that's the only thing that they feel like they're good at. Routines and certain rituals can be very important to them. So everything else that we've described so far relies on you know, working things out from basic principles. And sometimes at the end of a really difficult day, to go to their little routine is a way of self-soothing. And often it might come across your desk as, you know, is this OCD? When actually this is a child who needs to do these routines because that's how they're keeping themselves calm. Sometimes, you know, one of the parents might be somewhere on the spectrum as well, as there's often a, you know, a fairly decent genetic predisposition. And sometimes that can be a source of clash in terms, you know, dad or mum might come home from work and get irritated that the child's having to do their routines. And that can be a source of sort of conflict in the home. Their speech can be quite disorganized or tangential because they're just going at such a different speed. They're having all these amazing ideas, but they're not always connected together. You know, and often they'll end up in front of the early intervention for psychosis team, and that's really not what it is. The stereotyped and repetitive movements. So I'm sure you'll have all seen during the pandemic, the sort of the tick-like behaviour, you know, where everybody felt like they had Tourette's for a little while there. You know, there was so many girls who were ultimately on the spectrum who displayed that. And, you know, obviously you don't have to be very eccentric as a teenager to get bullied. So you can see that putting all those things together, you know, really often they then end up with comorbid mental health problems. Okay. So executive function, you know, this isn't just about language and theory of mind. There can be additional difficulties with sequencing, organisation, planning, and their working memory. So often they have reduced processing speed. That's how it would be explained in an educational psychology report. The way that I prefer to think of it is these children don't filter the information that they're being given. They take in absolutely everything, and that takes a longer time to process. So when I explain it to the children and young adults that I see, you know, I don't tell them they have reduced processing speed. I will say, you know, I know that you've told, you know, you could tell me right now how many things there are on the shelf behind me, what colour jumper I'm wearing, you know, do I have glasses on, all these different things. But you're also listening to everything I'm saying, and processing all of that information is going to take you longer than the next child who hasn't noticed those things. So I think that's really important, because they can often feel cognitively impaired and compare themselves to their peers. Their ability to self-reflect and self-monitor can be reduced. So, you know, the sort of the anger outbursts or the ability to control their emotions is reduced, but also the ability to see the impact that that has on others due to the sort of the reduced empathy. A genuine reduction in time management and prioritizing. So really 10 minutes is not 10 minutes, you know, I'm going to come off the PlayStation in 10 minutes. They will mean that when they say it, but their idea of 10 minutes is very, very different to everybody else's. Understanding complex or abstract concepts. So this is where the wheels often fall off when we get to secondary school. So if we all think back to when we were at primary school, everything was a bit simpler, and yet the information is presented in a more logical way. When you get to secondary school, the way things are taught, it's more about inferred concepts, abstract reasoning. And this is when really, you know, they could have been top of the class in primary school and then suddenly start struggling, you know, in middle school. And that's really important to kind of note. They're less likely to learn from their mistakes because of that ability to sort of self-reflect. And so they'll probably try again and again and again to carry on with the same problem solving, despite everybody's attempts to try and show them a different way. And that can mean that then their helpers, family, you know, the nice teacher can kind of disengage because they feel like they're being stubborn and not listening. A desire for perfection is something that we often see, often in the girls, but also in the boys. And can be the root of all sorts of different problems. But, you know, procrastination, difficulty getting started, struggling to move on if they've made a mistake, or if they feel that they've been wronged at school, for example, getting really, really stuck on things can obviously make it very difficult to get on with your schoolwork. And that can be another source of stress. So that's just kind of, you know, what autism really looks like on the ground, and I hope that gives it a bit more life, I guess, than you know, the sort of the textbook sort of 3 criteria kind of thing. So when would I think it would be useful to refer? I mean, firstly, it's if you suspect the diagnosis, and sometimes, you know, families will come to you saying things like it's something neurodevelopmental, or sometimes they will passionately believe that it's ADHD. And, you know, my response to that will be, well, we're in the right territory. You know, I think, you know, neurodevelopmental is obviously a big term. And I think if you feel that a child is presenting in that general area, I would consider referring. But usually what happens is families will present at the point where the comorbidity is the presenting issue. So usually when the diagnosis turns out to be autism in the end, they'll come to see me with low mood, self-harm, dietary restriction, or binging and purging, weight loss, so looking like anorexia, reduced school attendance, aggression in the family home, including property damage, or they might be running from home or running from school, which is obviously a huge issue for schools to manage. So, you know, everything that kind of tries to get to CAMS, I suppose, would come in there. And then, you know, often that will be because they're on the spectrum. The other group that I think get missed because their parents can't get them out of the house is those with demand avoidance. And they will often present, you know, bundled into a car because you know, the hygiene issues have become a problem. They've become nocturnal, and there's this pervasive refusal. And, you know, they can be a difficult group to help because you can't make them accept the help, but often just the explanation to family about what they're dealing with can reduce a lot of anxieties. Because I think all parents are sort of hardwired to think that their teenager is psychotic when they don't come out of their bedroom for 2 days. You know, we can't help it. So I think, you know, sometimes giving them the explanation that this is most likely autism, and, you know, that can help reduce some anxiety sometimes, at least. So in terms of what can be done, actually quite a lot. You know, a lot of parents will say to me, you know, well, look, if it's ADHD and autism, let's just treat the ADHD because you can have medicine for that. You know, you can't do anything about autism. And it's just completely not true. There's lots you can do about autism. And I would always, the way I manage it is I'll put the ADHD diagnosis and assessment on the back burner, if you like, because so many of the symptoms of autism can masquerade as ADHD, which we'll go through in a second. That often is met with some resistance because some families are more comfortable talking about ADHD than autism. But, you know, the treatment-resistant ADHD patients I've seen over the years are ones where the autism diagnosis has been missed. So it's really important to get the order of things right. So I think mainly it's starting with psychoeducation for the family and also for the school, you know, really reiterating everything I've said over the last few slides, helping them understand that this child is not being naughty, they're not being lazy, they are really, really struggling, and their anger and aggression and rude words, you know, are driven by anxiety. You may want to check their hearing and look for other neurodevelopmental issues. But, you know, it's very rarely that, but sometimes families want to start with that to make sure they've excluded everything. The biggest thing is about getting increased support at school, which is probably about as difficult as getting a CAMS referral, but, you know, there's a lot you can do to support families in terms of how to get help and support, and I'll give you some sources at the end. EHCP, Statement of Educational Needs, when we were all at school, but essentially it's funding from the local education authority to pay for their teaching assistant or their speech and language therapy or whatever it is that they might need in order to access their education. And I seem to spend a lot of my time explaining to families their legal rights to have these things. You know, we all pay our taxes. The local education authority, you know, has money for our children so that they can receive an education. So I think often it's about empowering parents to have this because they get told lots of different things. They get encouraged to deregister their children, you know, difficult things go on. For the child, if they're willing and old enough and they've come along in this journey and they accept the diagnosis, which usually they do, social skills training, so, you know, befriending and how to feel confident in the playground, that can really help. Emotion recognition skills, so in autism, the ability to recognize their own internal emotional state is reduced. They're very, very good at picking up on other people's emotions. So high expressed emotion within the family home is often very difficult for them, but they don't see their own emotions. So teaching them that can be really helpful. And then teaching them to regulate it is also very helpful. Not for all children, but for some, a speech and language assessment can be helpful. You'll find in a consultation that they're just really misunderstanding everything you're saying. They're getting the wrong end of the stick. They're repeating what mum and dad are saying, so they look like they're kind of going on with the appointment, but they clearly have no idea what anybody's talking about. And they've just been really good at masking. I would recommend that those children go for a speech and language assessment, because what you'll find is their level of comprehension is very much lower, significantly lower than their level of expression. And they've just been faking it until they make it their entire lives, which is obviously very stressful. So, recognizing the level of that deficit can, add to their case for an EHCP and add to the specificity of the help that they're going to get. Sensory profile is something that can be really, really helpful. So I personally see autism as a sensory disorder. It's different for each child, which is why we do a sensory profile, but I go on to list more about that in a moment. But it's a quick win that's not about using medication in terms of reducing sources of anxiety. Simple things like, turning off the fluorescent tube that's right over their desk at school means that they can now concentrate in maths, for example. There's some easy things to do there that don't have any side effects. In terms of medication, I think, I'm sure yourselves, and I know I often feel quite pushed to prescribe something can make this all go away and fix things. And, usually I would take the stance that, we have to try all of these other things that I'm talking about before we start prescribing, because otherwise we're medicating the child to fit into the system that's not helping them. And I think, once the parents understand, which is why the education piece is so important, once they understand that, that usually goes well. But, in that situation where, they've now got a teaching assistant, maybe they've been given a laptop at school, everything that has been done that could be done, being realistic about people's budgets and everything like that, then the use of an SSRI, usually fluoxetine or citalopram, can be helpful. Even sort of down to the age of 6 or 7 years old. And, I'm aware that that's a specialist prescription and it's off license for all these different things. And that's explained to families. It usually works very well. It's usually tolerated very well with minimal side effects. Very occasionally, children get more aggressive, but usually it leads to a lot of improvements, I think largely through reducing the sensory issues, and that reduces the anxiety. You often see a reduction in the OCD-like behaviours, but they don't reduce to nothing, because it's understanding that they're using them to self-soothe. So you have to let them do them, and it's good that they're doing them because they're regulating themselves. So it's about explaining to the family that no, we're not going to 40 milligrams. That's an OCD dose. They don't have OCD. It's good that they're doing the compulsions. So it's really about teaching the families what it is that they're looking at. Melatonin, I feel, is almost compulsory for these children. I forget the article, but they make less melatonin than the next child. They're really very much set up for initial insomnia, broken sleep, and waking up at 5 o'clock in the morning. That's kind of the way that they're built. And what you often find when they're struggling is this will kind of push them into sleep reversal. They'll stay up until 2 or 3 o'clock. They'll basically be awake all night when everybody else has gone to bed, which is quite a good way of avoiding mum who wants you to get in the shower or dad who wants to get you to go to school. And they'll stay up all night cooking, magnificent feasts, and then they're too tired to go to school the next morning. Some of those children, when it's part of pervasive refusal, don't want the melatonin because they don't want to fix that. And again, there's a whole piece about explaining to families about what that's about. They're avoiding you all because they can't even be around family right now. That level of social interaction is difficult for them. Very rarely, when aggression is a major issue and it's at the point where the child is going to need to be accommodated, social services may or may not be involved, but things are getting very difficult. Siblings might be getting injured, parents getting injured, things like that. you would look at a low dose of something like risperidone or aripiprazole. It's not a long-term solution, obviously, because of the side effect profile, but sometimes, you know, I'll have the open conversation with families to say, you know, that this might help until we get the special school or the EHCP is finalised, to prevent them having to, you know, put them into voluntary accommodation. And again, there's all the difficulties about getting the social care response, and so sometimes that is really a sort of backs against the wall kind of moment, and that's really difficult because you know it's not going to be forever. NVR, non-violent resistance, is a better way to manage it, and that's usually psychology-led, parental sort of systemic management of how to manage these moments of aggression. It's based on you know, historical, I guess, the models of sort of Martin Luther King and Gandhi and stuff like that. It's really about getting the message across without fighting with them. I could literally talk for an hour on NVR, so you know it's going to be very difficult to explain it more than that at this point, but it's very effective, and essentially it's recognizing that the child's very anxious, not able to control themselves, but equally they can't act out and break the house. So you have a meeting with them the next morning and you problem solve with them things that could have been done differently. But not just with the child, it's, look, okay, mummy was shouting, that wasn't helpful. You know, what can we all do differently to manage that situation differently? So I won't need to tell you guys, obviously, about the side effects of antipsychotics. And, you know, once they've been started, families are, of course, reluctant to get rid of them. So, you know, it's a very difficult step to take. So often it's about looking at the comorbidity. So nothing ever exists in isolation. You know, there's no such thing, in my view, as just ADHD or just autism. That's very, very rare. So, you know, often there may be comorbid depression. Now, whether you see that sort of biological or chemical depression, or, you know, a lot of the terms that families will use, the way I explain it to them, this is more of a sort of learned helplessness, that this child's been on maximal stress mode since they're about 4, and now they're fed up. You know, an antidepressant will help make them better. But I feel like it's quite important to explain that to certainly teenagers, that this is not the start of a recurrent depressive disorder. This is not you on tablets for the rest of your life. This is secondary school is a really difficult place, and being really stressed out every day eventually makes everybody sad, is how I see it. And that usually sort of resonates with them, because I think a lot of them, understandably, are quite anxious about starting medication. ADHD, I suppose we've touched on, is, you know, fairly frequently comorbid. I think it's really important to tease apart the symptoms and make sure that you're chasing the right symptom with the right medication. Learning issues, and then gender dysphoria, which, you know, again, is another massive topic, but certainly in female or born females, you know, there's often an episode of gender dysphoria that is really difficult and distressing, that is related to being on the spectrum. And, you know, I think there's a lot of politics, and it's easy to use the wrong words. And I think the best way to talk about this that I've found is, you know, please tell me if I get any of this wrong. You know, I don't mean to be disrespectful. You know, you can easily get it wrong, and I think it's just apologise if you say the wrong thing. At home, in terms of advising parents, it's keeping to regular schedules, avoiding unexpected change. You know, you can make a safe, low sensory space in the corner of their bedroom, so like a den, even if they're sort of 16. You know, you can make a nice little den with fairy lights, and a sensory box. So good reason to go shoe shopping, but then you know, something that smells nice, something that tastes nice, something that's nice to touch, etc., etc. And that can just help them kind of regulate themselves after a difficult day. Often communicating about their own emotions is really difficult. So there's plenty of websites that will produce these red and green wristbands. If you flip them one way around, they're red, and then if you turn the other way, they're green. And it's just a way that they can let the family know that they're struggling and that they're not open to communication right now. But it would be really great if somebody brought a cup of tea to my room or something like that. Always having contingency and safety plans. So A&E is the worst place to take these children, obviously, but sometimes you have 0 options. So it's trying to kind of let these families know what else can they do, but also when is it time to go to A&E. So just being really super clear with them, this is the line. And the child will never want to go, so it's always a very upsetting moment for everybody. So again, enabling parents to know when to worry, when to supervise, when to give them some space. And all of that is a lot easier when you're no longer talking about, could this be psychosis? Could this be OCD? Could this be anorexia? I think that clarity of it is this, it's definitely not that, gives you better edges to deal with. Then I think the other things to try and think about, once you've made the situation safe, is the other sort of, I guess, hand grenades that can get thrown in there when you've sort of steadied everything down. Often there can be sort of a safeguarding wobble of some sort. Either they're kind of catfished and sort of send inappropriate images of themselves because they thought somebody that was their friend, or vulnerable and easily led, or there's online bullying, which are all very difficult, and they will often find it very difficult to come forward about that. So it's almost sort of ask because I won't tell you otherwise sort of thing. Getting into trouble at school because they're mimicking other people and trying to fit in and trying to be cool, and other kids sort of setting them up, getting them in trouble so they get suspended and so on. So again, the diagnostic clarity so that families can go to school and explain all of that, because I think schools, once they get in the groove of deciding somebody's naughty, there's a fairly quick pathway out that I do see reversed very quickly when the diagnosis is made and the support does come. So it doesn't make a big difference. Usually what we'd advise families to do is go and have a meeting with the school, make sure that they've got an individual education plan. All children are supposed to have one, but schools have as much resources as everybody else these days. So, a child with a confirmed diagnosis needs a plan. They need to meet with the school to make sure that that's regularly reviewed and it's fit for purpose. And that does start to give them a little bit of legal rights, if you like, that tiptoes towards the EHCP process. If they don't have an IEP, that whole process can't start. So there's important sort of stages to go through. While you're getting everything sorted out, we often look at a reduced timetable. They can miss the school bus, they can miss registration, maybe they get to come home at lunchtime, etc., whilst the support is put in place. And often the more significantly affected children will go for a sort of a hybrid timetable where part of their educational budget might go for things like forest school or animal care or other ways of seeking their education. So that there's ways to make it all better, really. And if you can put those things in place, then the risperidones and the aripiprazole is usually not necessary. Sometimes, more rarely than anything, really, completely alternative provision is required. So specialist autism, perhaps residential schools. There's not very many around. They're expensive. You will have a fight on your hands with the local education authority to get one agreed through the EHCP. And, due process will need to be demonstrated that everything else has been tried first. EOTAS gets talked about a lot on a lot of the Facebook forums that these families seek support from. So that's education other than at school. So basically taking your budget from the local education authority and homeschooling your child. I'm sure that will divide the room. Some people are very pro homeschooling. It's not without its problems. And I always caution families to think about this carefully. You can understand, if they've got a young person who's tying ligatures and, destroying the house, and, they've identified that this is about school, you would take that option. And I'm sure, I would consider the same. But what they've got to try and remember, what happens at the other end? What happens when this child turns 25? They now haven't left the house for, 7 years or whatever it might be. So it's usually about trying to find a middle way, which is reducing the timetable, maybe forest school, maybe animal care, maybe something that they're passionate about, a cryptocurrency course. There's always a way to try and find a middle way before they go for the nuclear option. What I found more recently is schools are suggesting EOTAS to families, which is concerning, because as soon as the families deregister from school, and this isn't truly explained to them, to be fair, you're no longer the local education authority's responsibility. And I think that's a little bit tricky. So sometimes families have signed the paperwork before they've spoken to us, and there's nothing we can do. But often they're being pressured quite heavily to sign that. So, you know, that's something you can definitely advise them on pausing on. That's really helpful. So were you to have one of these clients in your surgery, you know, where can you send them? I won't labour the point about CAMHS. You know, Autism West Midlands is a really decent website for help with the education side of things, because navigating an EHCP process is painful and difficult for these families, and often the cause of at least mummy or daddy going on an antidepressant themselves. Sendar and Sendias are both voluntary agencies, and they're very, very good. Laura Costello, that's her email. I don't know her fees. She's everybody says that she's worth her weight in gold. She helps families through this process, and has, you know, various stock letters that she helps them send to challenge some of the decisions that are being made, you know, when children are getting suspended and sent home because there's no teaching assistant, etc., etc. So there are things that you can do that are not medication based. So I wanted to try and just talk about the sensory issues, because these are what I would see as the sort of the quick win, maybe not medication things that you can try that are often really helpful. So assessing it formally, if it just seems really confusing, which often is, you know, a formal sensory profile can be really helpful, because what you find is there'll be different sensory issues at different times of the day in different settings. And then it's really difficult for families who are new to all of this to kind of decipher it. So after a day at school, for example, they might be really sensitive to sound or touch. They can't have a hug. They need to take all their clothes off apart from their pants and run around the house, you know, and families don't understand what's going on, because at the same time they have a reduced sensitivity to pain, throwing themselves around the place, not noticing that, you know, they've cut themselves or whatever. And it's just really difficult for them to understand. But all sensory issues, in my experience, are worse when they're anxious for other reasons. So if they've had a bad day at school, the sensory issues will be more prominent, for example. So thinking of the auditory sense, you know, common triggers would be an electrical buzzing. So the sound of, you know, the fridge compressor, fluorescent tubes, dad scratching his beard, people clicking their pen, the squeak of balloons, bubble wrap, marker pen on a board. They're all examples of things that have led to children having, you know, aggressive meltdowns within school, and, you know, just the one little noise. So I think it's just a sort of the gravity of the situation, really. Often it might be sudden loud noises, so a dog barking or a car going past. Standard would be the hand dryers in motorway services, but it can be such a fight or flight response that they will run out of the place. So especially next to roads and all these different things, it can be a real safety issue. And then the other one is about loud and mixed sounds. So parties, people talking in class, you know, that can really sort of escalate their anxiety levels. The way they often learn to deal with it is they'll zone out and learn to switch off, or actually using noise cancelling headphones can be a useful tactic if the teacher knows you're using them. But obviously then they're missing out on the lesson, and people might think they've got ADHD, and it will affect on their ability to learn. So, you know, these are not small and trivial things. Touch, so they might stiffen, flinch and pull away when they're hugged or touched, you know, which will always upset the mums because they don't want to hug from them anymore. You know, you'll probably have them come into your surgeries where, you know, well, I think it's because of puberty, you know, maybe if they go on the pill, you know, because this all coincides with kind of moving up to secondary school. And it won't be about that, you know, this is about sensory issues. So a lot of problems with school uniform. So primary school, if you think about it, is often a nice soft polo shirt and, you know, jumper for ease of getting little people dressed in the morning. Secondary school is often a little bit more formal with, you know, proper shirt and tie, and that can bring out a lot of the sensory issues as well. They'll find that sort of the social gestures overwhelming. So a handshake or a hug, you know, these are just another reason for a meltdown, really. And then a classic one would be having their hair combed. So, you know, maybe school are calling to say that they're looking dishevelled, or, you know, is this an issue with neglect? And it's because they literally won't let their parents comb their hair. The sensory issues then obviously extend to their mouth, and that can lead to problems with dietary intake, which then they may present to you looking as like, you know, dietary restriction, and is this anorexia, when there's no body dysmorphia, there's no image, you know, body image concerns. This is about they don't like how the food feels in their mouth, but they can't really explain that to you. So there's ways that you can manage this. Occupational therapy can do sensory integration therapy, which is essentially desensitizing, having understood which are the biggest triggers, but also reducing the things that you can in the environment. So I often write a letter to schools to say, they're going to need to wear a polo shirt, because actually if they don't have to wear a shirt and tie, they can make it into school and they're not having panic attacks and they're not kind of, having emotional meltdowns. So simple things can make a really big difference. Deep touch, whether it's massage or skin brushing, can actually be soothing. And this is where it's confusing for parents because they don't like light touch or a little hug, but they will have a bear hug. And so sometimes teaching families that can really mend bridges because they do want a big bear hug. They just don't like the sort of the wishy-washy hugs. Suggesting that the kids maybe get into martial arts and combat sports and rugby, whilst that sounds crazy, it's because it's deep pressure and the contact is actually quite helpful. With the oral sensitivity, this is why they want predictable food. So, I'll only Aldi pizza, or, it's got to be a certain brand of Marks and Spencer's macaroni cheese or something like that. If they've had a really overwhelming day, then the sensory issues are on maximum and they need to know what something's going to taste and feel like in their mouth before they'll even consider eating it. So helping families know that they're not being a diva, they're not, being spoilt. This is not about sending dad out from McDonald's at 11 o'clock. Once you understand it's because they've had a difficult day, it then makes a bit more sense. But usually they'll want beige and bland foods, no sauce. And parents we're all programmed to worry about the amount of vegetables they'll be eating. So, it's trying to explain to families, when to push, when not. But always to avoid force feeding. Mostly these children will manage to eat enough of something. It may not be the foods that we really like them to eat, but they will usually manage to eat enough. But the things that we do in our clinic is, we'll do taster boards where, in a maybe a mixed setting with the family. So it's not all about the child. You'll have a board with a number of different things on they can taste. There's no expectation to eat them. They just need to lick them or smell them or even just touch them. So that's how you kind of desensitize. Positively encouraging the iPad at the breakfast table, which, is very difficult for often the dads to kind of understand that this might be helpful. But really avoid making the issue into making it into an issue, because it usually passes with a bit of sort of gentle ignoring, if you like. So sight and smell, moving on through the senses. Often it will be about bright lights. So you'll see adults, wearing sunglasses for this purpose, but you can't do that as a child. Fluorescent strip lights are often a problem. But also seeing a whole person's face can be quite overwhelming. So there's been interesting things with the pandemic because a mask was obviously showing you half a face, and then going back to a whole face, people have found overwhelming. But then getting quite distressed by shadows and dark places because there's sort of that uncertainty feeling. And so sometimes you'll kind of get them referred to clinic query psychosis because, they're getting this anxious kind of paranoid feeling around dark spaces. And you're not actually about this sort of sensory issue. They might be, their special interest, if you like, might be about seeking out patterns and being rather obsessed about that. So you might see them sort of, walking along, studying the tiles in the floor and counting them, for example. Things that can help, that they can have in school. They won't get bullied for, tinted lenses, or, the reactive lenses that will kind of go dark when they go out into the playground and so on. And, they can be prescribed, I believe, and they can be really helpful. Smell is often a big issue at home as well, and often a source of family argument, which then leads to more stress. But cleaning solutions, mum's changed the perfume, or there's a change in washing powder, cooking smells, that can all be really difficult for them. But also the dining room at school, if you think about it, it's a very noisy, echoey place with multiple conversations going on at the same time. There's a social expectation, and there's the school dinner smell. That can often be a trigger for them just not wanting to eat at school, and then off we go with all of the associated eating difficulties. Pain and temperature. So often they have quite a high threshold to pain, so they might present to A&E 3 days later with a broken arm or something like that, and insensitive to temperature. So big arguments with mum and dad, won't put my coat on, and turning up to my appointments in shorts in this weather would be a telltale sign before we've started taking the history. So that's kind of quite classic. but also really intolerant of heat. So then that might lead to, aggression and problems at school when the central heating goes on. So, it's understanding those things. The lack of response to pain obviously can be risky in that, they're not very careful with themselves. They throw themselves all over the shop, lots of cuts and bruises, not bringing to people's attention the fact that, the bits are sort of nearly hanging off, but, putting up with pain for too long. So, often an undetected ear infection, tooth problems, broken arm. I've seen all of these things. So it's kind of letting families know that, they just need to keep a good eye and look for other sorts of sources of or signs of pain. So maybe like their heart rate is really high, or they're not using that arm. It's going to be more subtle. I just put synesthesia in there just because it's kind of interesting, but not necessarily clinically helpful in this context. But basically, a sensation in one system is registered in another. So hearing in colours would be the classic example. I think it's really rare. I think these children really struggle to describe their emotions and sensations anyway. So it may be that a lot of them have it but don't talk about it. But it might be an explanation for why sometimes, for example, Christmas dinner, they need to go and sit in the room next door to be able to eat it because there's too many other things going on. So anxiety and compulsions. I think anxiety, obviously you can reach for an SSRI, but hopefully I'm impressing upon you that a lot can be done in terms of supporting the family to make sure they get a good deal from school. They get the help that they are supposed to be getting, teaching them what they're entitled to, and really just empowering them, putting them in touch with the right people and trying to encourage them to go down that route first. I will always say to them, that an antidepressant, it is not rationed. You can absolutely have it. I just want to make sure you do these things first, because otherwise we're medicating the child to fit in with everything else that isn't being done for them. And once you say it like that, they're then quite empowered to kind of go and fight for the things that they need. Looking at the sensory issues, as we talked about, because they're really quick wins, they're easy peasy, and they work straight away. And obviously there's no side effects. And then medication, once you've run out of ideas, frankly. The compulsions, explaining often repeatedly to families that this is not OCD. It can be washing their hands repeatedly, pacing, counting, tidying, doing that makeup and hair for hours on end. But it's, once you've obviously taken the history and reassured yourself that it's not OCD, it's explained to families that this is self-soothing. This is because they've had a bad day. Let them, it's okay, and I think because families worry that they're doing harm by not intervening. Obviously, if it becomes excessive, if they can't come out of the house until their fringe is perfect, would be a classic, then you're going to be thinking about medication. CBT, obviously is used for OCD. In my view, I'm not sure that these children can access and use CBT easily because it relies on their ability to understand they're in an emotional state, which they can't do. They're usually very polite, go on to the sessions, get nothing out of them, and then feel like they've failed because it hasn't worked. And I think, CBT is excellent for OCD. I'm not convinced it is really that useful for this client group, which will probably upset many people, I'm not sure. Aggression, sorry, that's so small, but there's quite a lot to say. And I guess this would often be a reason that people present in crisis and are demanding things because it's getting really difficult. I think the really important thing is it's, in my view, always driven by anxiety, overwhelming anxiety from the young person, that they lose the ability to communicate when they're really stressed. That's already impaired. They can't influence what's going on. They don't feel like people are listening to them. They don't feel like people understand just how stressed they are, and it leads to anger. Something's going on with the presentation. It's going ahead without me. I'm not sure. So they tend to blame everybody else when things go wrong. They lose their temper. In that situation, they're not going to be able to have the ability to self-regulate or reflect. And like I said earlier, they lack sufficient empathy and self-control to respond in a proportionate manner. So there's lots of lashing out, and they're getting cross with their mum because they're crying, for example. So it's really, really difficult for families. Again, after lots of explanation, it's about relaxation strategies, tackling the sources of anxiety, and then, communication skills, encouraging them to use their words rather than their actions. A very clear message that despite having a really bad day, this isn't acceptable. You know, yes, you're autistic, but that does not mean you can hurt mummy or break this. You know, that there still has to be consequences. It's just how they're delivered and how you communicate to the child that we are still working to fix everything else, but you've got to learn a different way to deal with this stress. So it's kind of, because I think sometimes families will come thinking that the child, you know, is really psychiatrically unwell, and that, you know, really they have to give them everything they want, otherwise they're going to make things worse. And so there's often a sort of a re-education about that as well. Trying to intervene at an early stage rather than waiting till it blows up, because once, you know, the aggression has happened, there's very little you can do. And I think avoiding reinforcing, so schools, you know, very much may, you know, send them home. You know, they've hit someone at school, let's send them home. But all that's going to do is reinforce anger, because they want to go home. So I think it's about having some interesting conversations with school about, please don't do that, because actually it's going to make things worse, which it really depends on the school. Sometimes they're open to that conversation, sometimes they're not. At home, when you see that they're in that mood, you know, we talk about creative destruction. So they can do the recycling for you. They can go out and stamp on all the beans tins and put them in the recycle bin for you. They can go and smash all the boxes up. They can do something really useful to get rid of all those feelings. In the moment, you know, often what we'll tell families is, don't shout, don't lose it. They will, we all do, everybody's human, but really they need to try and model a calm and rational person. In time, the child, if they've hit someone at school, they're going to need to apologise. There has to be consequences, and they need to do some sort of reparation. So, you know, in primary school, it might be, I've made you a nice card. Secondary school, it's going to be more involved, but, you know, there has to be some sort of comeback, not on the day. Usually you have to leave it quite a while before that can happen. If, as said before, you know, if you've tried all of the things that we've talked about, and this is ongoing, you know, and social care and all these different things, then again, you might kind of think of the low dose antipsychotics, but again, it's really not a long-term solution. And the non-violent resistance that we've talked about a little bit before. Friendships and relationships, often a cause of significant and apparently sudden deterioration. So whether it's a breakup with a boyfriend, or more often sort of a split in the friendship group and being excluded, you know, these cause lots of problems. Sometimes, you know, a non-reciprocated crush. So they really thought that the person liked them back. They might get obsessed. They may be, you know, texting them too much, and it can start to become a bit of a sort of safeguarding issue when the other person doesn't feel the same way. And that can be quite difficult to manage. They're quite vulnerable to assault. So, you know, not reading the situation, ending up in the park, not seeing that coming, and then ending up, you know, with a situation that they did not invite. They usually sort of tend to spend time with children of similar interests, or somebody who can do the feeling stuff for them. So often kind of gravitating towards quite controlling children, or children that have got sort of quite difficult home lives and may have sort of emerging personality issues. And it's a really toxic combination, because they get very overwhelmed with the other person's feelings, but they want to be a friend, so they kind of consume all of these difficult feelings and then get overwhelmed. In later life, you know, may seem aloof and cold, and can be sort of, you know, marital issues and so on. So, you know, can have a meaningful relationship. It just needs a little bit of support and help sometimes through that tricky secondary school age. And the outcome, I think, you know, if recognised early on, if the right help is put in place, it can be great. I think the damage, in my view, is always done by it not being recognised. You know, and, you know, there's only so many suspensions and detentions that you can have before you start to think that maybe you're not a nice person, you know. So it's the kind of the impact on their self-esteem, really. So as family members, it would be that we'd, you know, encourage them to look for opportunities for success, boost their confidence, do the things that they're good at. Spoon theory is something you might have heard of. It's really, there's a certain amount of social interaction that they can be comfortable with in a day. Where do they want to spend that? So helping them to kind of go, well, look, I don't want to go to the party, but I'm really looking forward to horse riding tomorrow, and that's fine. When they're a bit older, support with budgeting and self-care and just those things that need a little bit more planning. But these things can absolutely be learned, and you know, they do really well in the end. But I think the most important message I can give you of all is they can be successful, but it's on their terms. You know, so they may be the best cryptocurrency person in the West Midlands in their bedroom, and enjoy playing Dungeons and Dragons. And if that's their happy place, then I personally think that we have to respect that. So I think it's helping orientate families to the fact that they can be happy and not have millions of friends, and be out every day and want to go to Merry Hill or wherever it might be. They've got their own version of success. So thank you for listening. The little picture at the bottom is of my other clinic, which is in Redditch, so the other side of the Midlands. And obviously I work at the Nuffield near Leamington Spa. I'm very happy to be emailed with any queries or questions. And if there's any other topics you want me to talk about, I'm very happy to do so.
Thank you very much, Sasha. Does anybody have any questions right now? If you do, please put your hand up or type it into the chat. If there are any other topics that you want Sasha to talk about, if you can pop it onto the feedback survey, that would be helpful. Yes, Becca? Do you want to take yourself off mute?
Yeah. Hi. Thank you. That was really interesting. I'm sorry I missed the just the introduction of your talk. Are your patients mostly children, Sasha, or do you deal with adults as well with learning disability?
So
and autism?
0 to 25 is
25.
yeah.
Okay. I just wanted to get your advice because I've been getting a lot of queries from adults lately with concerns that they may have autism or ADHD.
Yeah.
And I was just wondering how to best approach that. And if you had any sort of advice regarding that, because I'm a GP and it's a long consultation. It's a lot of questions to go through. A lot of these people are often, functioning very well in jobs and looking after home lives and stuff. And you don't want to be belittling their concerns, but you also don't want to be putting work towards mental health or LD health that is already dealing with an awful lot themselves. So yes, if you had any advice regarding that, I would appreciate that.
Up until a few months ago, we were doing those assessments for adults. Lisa Brownell, who's a well-known Birmingham adult psychiatrist, would have those sorts of clients. She's taking a break at the minute, but hopefully we'll be starting again next year, in which case we can start those again. What we would always say, when I've seen those adults myself, is really, why do you want this now? What is the purpose of sorting this out now? Because if they've been successful, if they've got through school, they've done the kind of the mostly difficult bit, you've survived this long, what is the purpose of doing it now? What will it give you? Because a lot of these assessments will be done privately and self-funded, and it's a significant amount of money, and it's really, why is it that important to you? I don't want to take your money off you because I'm not quite sure why it is you want that. And so kind of getting to the bottom of what is it going to help you know. And sometimes it's just, I just want to know because I have an autistic brain and I need to know the answer, and I just need to know. I don't expect anything else to come from it, in which case I think that is a valid answer, because it's a bit like having a scratch that you've got to itch. But I think sometimes if it's like, well, it's going to fix this and this, and it's like, I think you have to kind of manage that expectation, which you're going to really struggle to do in 4 minutes or however long you guys don't get. So I think I suppose I would just try and hammer on with why now. I hope that helps.
Thank you. I think that's often the question that I do sort of try and pose to people is what are you hoping to achieve from that, from getting that diagnosis or getting that question answered. And for some it's, they can't really answer it, and some they have very clear ideas, and that makes it a little bit easier. But that's very helpful. Thank you.
There is another question here that I think says, was that Lisa Brown for a new adult diagnosis?
Yes, Lisa Brownell. So Brownell, ELL on the end of that. she's fab. And, you know, so she because she's an adult psychiatrist, and I think it would be inappropriate for me to diagnose an adult without an adult psychiatrist involved. So, you know, we have partnered up to do that, because, you know, we both work in a very similar way. I'm hopeful that in the new year, you know, that will be back again. So, you know, if you do have adults, contact us if you want, and then we can let you know where that's at. Because, you know, I think it's a good thing that this is more prominent in the media and people know about it. And so I think, you know, a lot of these adults that are coming forward, you know, it makes sense. But yeah, I don't think it would be reasonable for me to do it without an adult psychiatrist involved also.
Another question, are there any online platforms that you recommend for people to self-refer to for self-reflection / assessment questionnaires?
No would be the short answer. I think they're usually quite good at finding sources that seem to say everybody's autistic and everybody's got ADHD. You know, I think a lot of the bigger corporate providers, you know, will have some of these questionnaires on their website, and it will be, you know, oh gosh, it looks like you've got ADHD. Why not book in for an assessment? You know, so I think, you know, the Conners rating scale that we use for children, it's not great. It's rubbish for girls. You know, the QB is, you know, a computer-based test that is the gold standard. But, you know, they need to have an appointment to have that. I think questionnaires are so difficult because if they are somewhere on the autistic spectrum, that ability to self-reflect and be self-aware is not going to make you very good at doing a questionnaire, if you see. So no is the short answer, which I know is not very helpful, sorry.
Are there any other questions? If there aren't, then that is the most perfect timing. It's just flicked over to 8 o'clock, so that's brilliant. Well done. Thank you everybody for joining us this evening. As I say, we have got some lectures in January. I will send out some invitations to you for that. And hopefully it's not too early to say Happy Christmas.
Happy Christmas. Thank you.
Thank you, everybody. Good night.
Thank you. Great talk.
Thank you.